Thank you very much, and lovely to be back in Palermo. Thanks to Professor Ciccinini for the invitation to be here in this absolutely beautiful city. So I was asked to discuss this topic, focusing particularly on breast cancer, and we've had two lovely presentations talking about the background to fertility preservation and the need for it in patients in general. So today, as I say, focus particularly on breast cancer. And I think the reason why this is such an important condition to consider in this context is highlighted by this dramatic change in the survival from breast cancer that occurred in the around about 1990 in the UK, and that was really the recognition that these patients required chemotherapy as well as just surgery, potentially radiotherapy to the affected area, but they required systemic chemotherapy to improve these survival rates. And of course that comes at significant cost to their reproductive function, as these therapies are largely alkylating agent based, often with cyclophosphamide, and therefore carry a very substantial risk of gonadotoxicity. Hamish has showed you these data as well, and I include them myself in this presentation to highlight that amongst fertility preservation patients generally, most centres who have referred on the indicating diagnosis show that breast cancer is actually the most common diagnosis for women to come forward and seek fertility preservation. And indeed, as Hamish said, they make up overall approximately a quarter of the number of pregnancies that don't happen as a result of cancer. So a very important diagnosis with a major impact in terms of the likely loss of fertility in this group. And they also don't have long to achieve a pregnancy. It's obviously mostly a postmenopausal condition, and even in the patients who are presenting, who are still fertile, they are amongst the older age patients that we're going to be seeing. So in the general population here, you can see that here we have a rate of change in the normal population, here achieving pregnancies over a period of time. You can see in the breast cancer patients, they don't have such a very long time to still achieve a pregnancy, compared to, for example, the younger patients here with Hodgkin's. You can see they have a much longer period to then go on and have a pregnancy. So there are significant issues here, and of course there are post-chemotherapy treatments with endocrine therapy, and many of them that are also going to potentially affect their chances of deciding about what is their priority. Is it to continue with their endocrine therapy or to think about having a pregnancy? So if we think about what the treatments for cancer are going to have on the ovary, obviously these alkylating agents and other chemotherapies by definition are predominantly targeting proliferating cells, and granulosa cells of the follicle are amongst the most rapidly proliferating in the body in a premenopausal woman. So they will immediately then target these growing follicles as the primary issue. But of course, in terms of a longer-term effect on fertility, what we are particularly interested in is loss of the primordial follicle pool. But I think we also need to remember other effects on the ovary, particularly on the vasculature and indeed on the stroma. What are these effects? And these are actually relatively poorly defined. We don't have very good ways of assessing this in vivo in our patients. And this will go on and have the clinical consequences of premature ovarian insufficiency, POI, as we're going to term it this morning, infertility, and of course, importantly, loss of estrogen production and a very long period for many of these women of estrogen deficiency if they carry on surviving their condition. So it's been recognized that for many, many years that one of the most important determinants of whether a woman's ovaries will still be working after her chemotherapy for breast cancer is how old she is at diagnosis. And this is a very nice prospective study from the US of several hundred women, in fact, following up as to whether they had ongoing menses after chemotherapy. And you can see how dramatically it changes from those who are in their early 30s and younger, through about 90% of these women will continue to have ovarian function after chemotherapy, whereas by the time you get into your 40s, it's really fallen off a cliff, and it's down now to less than a third of these women. But not all of them. It's still about a third will still have some ongoing ovarian function. And we can think, and we generally would assume, that most of this is going to be related to the very well-known established decline in number of follicles that these women have. So as you're younger, you have more follicles, you will lose perhaps, say, 80, 90% of those follicles during your treatment, but in a young woman, that will still leave a larger number than in older women, and the ovary then has mechanisms for eking them out and using them more efficiently for a longer period of time than in an older woman. So how can we use this information, and can we actually assess this in patients, and can we use this to help individualize the discussions and advice that we might have with patients over this? So we can refine this model a little bit more, and instead of just thinking, well, yes, it's going to be just a clear-cut effect, we can think about perhaps a loss of all the growing follicles at the end of chemotherapy, and many women will become amenorrheic immediately after chemotherapy, and then, of course, there will be variable recovery. And some women then will go on and have recovery of ovarian function. Their ovaries may appear to be functioning normally, and they will have a period of time for fertility, and potentially, yes, an earlier menopause. Others, of course, will not show recovery. Their ovaries will be permanently damaged. They will have irreversible and complete loss of the follicle pool and have a permanent menopause and POI immediately thereafter. So can we assess this? And of course, the hormone that we might be able to use to assess this is anti-Müllerian hormone. Estrogen, FSH, those are hormones that are all about ovulation and whether the ovary is producing the Graafian follicle of the month or not. But perhaps something like AMH might be useful to look at the early stages of follicular genesis and to give us some information. And this is an immunohistochemical image of a monkey ovary, in fact, very similar to what you might find in a human ovary, but I think it illustrates very nicely the key issues here. And that is the production, see the intense production of AMH by these small antral follicles, and equally importantly, where AMH is not coming from, and that is the Graafian follicles here, and I think there's one down here, it's difficult to see from here, and indeed the corpus luteum. So this is a temporary production of AMH by these smaller follicles that switches off when the follicle gets more mature and is proceeding towards ovulation. And we all use this in our clinical practice as a marker of what we rather loosely, I think, term the ovarian reserve, and it's used by IVF clinics around the world to determine their protocols and advise patients how well they're going to do. But we use it as a surrogate marker of the number of primordial follicles. But the data to support that are really quite modest, and this is one of the very few studies that actually has looked at this in women, and it's based on only 42 women. A lovely study, very important, but I think we need to recognize the modest number of data points that make up this analysis. But you can see here in this panel on the left how there is a clear and very statistically significant relationship between AMH levels in serum in these healthy women and their number of primordial follicles, very carefully measured histologically after surgical removal. So that's an important relationship. But actually, there's just as good a relationship with ultrasound-determined antral follicle count, and actually, statistically, the relationship between age and primordial follicle number is actually a little bit tighter. So there are some limitations, both in terms of the strength of the relationship and the data that we have that underpins our understanding of that relationship. As I mentioned, we know that follicles make AMH when they're growing. Most serum AMH, in fact, seems to come from follicles just at the time when they are going to become recruited to become that dominant follicle, when they're about 5 to 8 millimeters diameter. And that stage of follicle growth is thought to make up about 60% of the amount of AMH in a single blood sample that you might take. So those follicles are, of course, within a few days, 10 days of potential ovulation, and they're a long way from when they were primordial follicles. Weeks and weeks of growth and selection have gone on between them starting off as a primordial follicle and going on to be a dominant follicle. As a further caveat, we need to also remember that AMH is not a fertility test. It isn't a fertility test in IVF. It doesn't predict live birth rate. And in the general population, it also has limited value as a marker of how likely a woman is to get pregnant. And there are a couple of very nice prospective studies in the literature now looking at this. And this is one published relatively recently from Ann Steiner and colleagues in the US, looking at women with low, medium, and highish AMH and trying to get pregnant, and you can see in the yellow, those with the lower AMH had exactly the same likelihood of achieving a pregnancy over a year of follow-up as those with much higher AMH. And there are similar data from Kasper Hagen in Denmark looking at showing the same relationship in women predominantly in their 20s, that having a low AMH doesn't impact on your likelihood of getting pregnant. So with those caveats in mind, what can we use this for, and what do the data show us about the relationship between AMH and profiles of this longitudinally from before treatment, through treatment, and into recovery that we might be able to use to understand what's going on in the ovary in terms of the follicle pool, and actually perhaps some useful information for our patients. So this is the sort of concept slide that I sort of use in my mind to work through this, and I can show it a number of occasions during this talk. And so it's a model of AMH, or in general terms, ovarian activity, ovarian function against time, and you can visualize three groups of patients with high, medium, and low activity going through the shaded period here. This is the period of their treatment. It will all dramatically fall. They will lose all these growing follicles, and then you'll have variable recovery. And there may be some women who maintain no recovery, women who have immediate acute ovarian failure and are permanently menopausal. And then you have recovery to variable degrees and for variable lengths of time as well. And one might postulate that those who start off with a very good ovarian reserve and a high AMH are more likely to bounce back higher and for longer than those who start off at the lower end of the normal range. So this then leads me to the question that's in the title of my talk of, can we use this information, can we measure AMH here and actually predict, does this graph really hold up as a relationship between before and after treatment, or are there too many other variables involved that will actually just upset all this relationship? So we did a couple of studies that involved recruiting women at the time of their breast cancer diagnosis. You can see that their average age is at the later end of the reproductive spectrum. We follow them through their really prolonged and complicated journey through all their surgery, chemotherapy regimes, and you can see in this initial study we did, there were a lot of different chemotherapy regimes flying around at that stage. And then they go on to their post-treatment follow-up, and eventually, we decided that we wanted to follow them for about 4 or 5 years. We then do an assessment of their function, and essentially what we want to do is assess their ovarian function there and relate it to what the situation was before they started this whole journey and had at pre-treatment. So do pre-treatment markers predict long-term post-chemotherapy ovarian function? So if you follow these women initially, what you see is the dramatic changes in their endocrinology during and after their therapy. With AMH here, you can see this is the hashed area, this is the duration of their chemotherapy, and this is years since diagnosis here, and this is months since diagnosis in this slide, and you can see how dramatically and rapidly AMH will fall to pretty well undetectable levels in everyone in this type of treatment, this type of patient, and very, very little recovery thereafter. Other hormones bounce about, as you might imagine. You can see some nice changes in Inhibin B, but about a 50% decline here compared to the 90+ decline in AMH. So this is not, you can say, well, actually, you're not showing much recovery here, but we know within other situations, AMH can show very nice recovery. And this is data from a younger cohort of women treated for Hodgkin's lymphoma, in fact, some unpublished data that's actually under review at the minute. And you can see here, AMH here during treatment and recovery, and you can see, depending on the treatment they get with relatively low-risk ABVD, a very nice recovery, whereas higher dose alkylating agent regimens, Biocop, show very, very little recovery. So AMH can reflect this, and it's then the question is, how much is it really going on in these breast cancer patients? So when we came to analyze the data at the end of the 5 years, this was a very long study, we can see that actually AMH levels pre-treatment were substantially higher at diagnosis in those women who still had ongoing menstruation 5 years later. And indeed, in a multivariate analysis, this stood up very robustly of about a 3 to 4-fold higher level of AMH at diagnosis in those women who still had ovarian function. So that was a very nice cohort. We followed it up with a second group of women to try and validate this. Is this something that we can really rely on? Another group of women, again, the same paradigm, but this time we just followed them up for a couple of years, and again got a very similar result. But it does also highlight the importance and the interaction with age here, and you can put the data together into this sort of mosaic chart where you measure, well, you know the patient's age, you measure their AMH, and this can you can plot where that patient is at diagnosis, and it can give you an idea of how likely they are going to have ovarian function thereafter. Clearly, the older they are and the lower the AMH, the much more likely they are that their ovaries are not going to survive the treatments. So yes, going back to this graph then, it does appear that pre-treatment AMH can help predict post-ovarian function, and in particularly women who are down this end, you can be fairly confident you can identify those who will definitely become menopausal thereafter. And others have used this type of approach as well. This is data from Arian Su in California, who did a comparable analysis, but basically teased out which were key factors and gave them a score, and this was age, AMH, and BMI she also identified, and this is looking at their time to ovarian recovery after chemotherapy, based on these scores. But it didn't have a differential weighting of this, so it's difficult to know which is the more important. It's just a score of 1 for each of these 3 particular points. Now, an important area of this, then, is this recovery, and can we actually identify women who are not going to recover? Because this might be very important in choosing their post-chemotherapy endocrine therapy, for example. And we then started to, at the time, it was fortunate that companies were starting to produce AMH assays of much better sensitivity. AMH laboratories were doing a lot of work in that, and we were able to collaborate with them to test out their very, very sensitive AMH assays in these women. And we were able to show that women who were amenorrheic a couple of years after chemotherapy had very much lower AMH levels than those who had ongoing menses, as you might expect. But importantly, they stayed there, and they remained amenorrheic. So if your AMH was undetectable, it was a very strong likelihood it was going to stay that way. So then the question is, well, you know, the diagnosis of POI is very much based on amenorrhea, high FSH, and low estradiol. But you would imagine that can AMH be a useful part of this diagnosis as well? Because these are difficult tests to interpret, particularly in the post-chemotherapy situation where things might be changing. And of course, there is the added influence of endocrine therapy as well. So to do this, we have another cohort of patients. This time from a trial called Option, which was a large RCT of whether GnRH agonists might provide ovarian protection. And actually it did, so that's another story for another day. But nevertheless, we can use these data to try and see how useful AMH might be in this context. So this is their profile across treatment, divided into those who did develop POI at 2 years versus those who didn't. And you can see, as I've already shown you, pre-treatment, there are very substantial differences in their AMH, and they go on to they remain very different thereafter. And you can see here, therefore, the area under the curve of predicting recovery, the AMH provides a very good marker of that. But it's also important to remember that age is a really key determinant here. And if you look at the recovery divided by age, those under or over 40, you can see that those under 40 showing a very nice recovery of AMH levels, of course not nearly to as high as they were before, but a substantial recovery, whereas those over 40, even when they had their AMH levels were not actually terribly different pre-treatment, you can see absolutely very little recovery in these older women. So age is an independent factor here for predicting recovery. To clarify then, can we use AMH to diagnose? Well, yes. This is the analysis here. You can see that you've got two groups here, and you've got very clear differences in their AMH at 2 years. And if you do an area under the curve analysis, you can actually get extremely good sensitivity for whether AMH is detectable or not using this very sensitive type assay, and this was actually using the Roche automated assay that in these women you can identify those who are not recovering, and pretty good specificity as well. So the next step then would be to think, well, actually, how far can we push that back? It's useful a couple of years, 2-3 years after diagnosis. You can identify those who've got ovarian function or not fairly accurately. But actually, what about in this stage? Because you can see in the schematic, the lines are a lot closer together, but is there still room for some discrimination in terms of being able to predict which women are going to recover or not? And that, in an oncology context, is very, very important, might become important if it was true, because then you could identify these women who would then be more likely to be treated or suitable to be treated with an aromatase inhibitor, rather than these women who need ovarian suppression with Zoladex or another GnRH agonist, as well as an aromatase inhibitor or tamoxifen or another endocrine therapy. So this might have a major value in determining their post-chemotherapy regimens. So if we looked at then a sample taken fairly close at the end of chemotherapy to how good that is going to be to predict what's going to go on a year or 2 years later, you can see that FSH clearly has value, but AMH is rather better and is able to predict more accurately which women are not going to recover their ovarian function at 2 years thereafter. But it's difficult because, again, we have age, and in these young women, they will often show the majority of them will show recovery, and some of them even from undetectable levels. So more accurately, if you then combine that with an age factor using a cutoff of 40, you can then start to get a much more accurate predictor. And indeed, if you look at their later estrogen production, because of course this is what the breast oncologists are worried about, are they going to show some estrogen production, potentially stimulate residual disease? You can show that those over 40 who had an undetectable AMH at the end of treatment did not show estrogen production, whereas some of those who had a detectable AMH did go on and show some estrogen production. So this needs refinement, this needs further data to substantiate it, but it might be a useful way not just of helping women decide what their long-term endocrine or potentially even fertility future might be, but also potentially their therapy. So just to summarize then, I hope I've shown you some data suggesting that pre-treatment, we can certainly help identify those women who are more or less likely to show ovarian function thereafter. Post-treatment, I think it's going to be, with these new assays, with improved sensitivity, it is going to add value to our assessment of ovarian function and potentially become part of the diagnosis of POI, which is such a difficult diagnosis sometimes in these fluctuant conditions, and potentially, with further refinement, some useful data to be obtained from the immediate post-chemotherapy regime, trying to identify whether or not women will recover or not. So in conclusions then, I hope I've convinced you, perhaps, that both age and ovarian reserve as measured by AMH have some value here. I can't emphasize enough that how important age is as an important part of this analysis. And I think that actually what we're starting to see is, what we're starting to need to think about is what are the effects of age on the ovary beyond just the declining follicle pool? What is the aging process in the ovary? And these, of course, are going to be relatively young women. These are not the rest, the aging that we all see in the rest of our somatic tissues occurring when we're in our 60s, 70s, and 80s. These are occurring in the 30s and 40s, and I think that's going to be a very intriguing part of understanding ovarian biology, to look at the differences, work out the differences of what's going on then. And my thanks to our funders, and also particularly my colleagues in the Edinburgh Breast Unit, particularly David Cameron, who's been a fantastic supporter in all this. Bob Leonard was the lead investigator for the option trial, and thanks to all of those, and some support from those making the assays. And thank you for your attention.
And we can